Thank you, Ed. As you may know, we're expecting that at least a few of you are not familiar with some of the language of prisons and jails and incarceration and stuff like that. So I'm going to do just a little bit, a very tiny bit of a primer to continue the kind of explanation that Ed was doing. But I would like to say that had I heard Gina Samuels talk before I made these slides, I would have called our presentations Cracked Up, because that's what this is. These are the youngsters, juveniles, and young adults who have cracked up at least once, and that's what this is about. Ed used the terms prison and jails. Prisons are usually state-operated or federal facilities for people who have felony convictions and sentences of a year or more. Jails are county and local facilities for people who are detained before trial or who have sentences of a year or less. So how can you guess, out of the 2.3 million people incarcerated on an average day in this country, how many of them are 18 to 26 in state prisons and state and federal prisons? Someone want to take a guess? No, give me a number. Thousands. A million. And what do you think for jails? Out of the 9? Oh, he separated. I separated them out. All right. Let's back up. We have 1.1 million in state and federal prisons. How many of those 18 to 26? 700,000, I hear. And how many of the 900,000 in county and local jails? Another 700. And what proportion male? 98%. 98. And what proportion black or Hispanic? 98. Well, here's what we got. There are about 650,000 adults. I interpolated these data from data sets that reported in different age categories, but I think that's approximately right. 93% male, 61% black or Hispanic, and the males and females are very different from a health and healthcare point of view. They're scant or no age-specific literature for prisoners. Healthcare policy in the context of the criminal justice system is absolutely uninformed by data. Absolutely uninformed by data, and often uninformed by any rational sense about what we know about people, patients, young patients, old patients, or whatever. Young and old behind bars are typically treated exactly the same. Now, I'm talking about adult prisons, 18 and older, with very few exceptions. They're treated exactly the same, notwithstanding what we know about cognitive and sensory deficits in older inmates and developmental needs in younger inmates and things like that. The fortresses of the prisons, I say, are rigid because they're mostly impenetrable, and I say they're barren because there's not a lot of thought about what we need to do to make a difference. Mostly in the United States today, people are behind bars for retribution, not for restoration of whatever function can be restored. Likewise, what drives healthcare in the community, healthcare is driven, well, we don't have a real system, but it's driven in some part by mission, it's driven in other parts by greed, it's driven by a lot of things, but not like behind bars. Healthcare is driven only by one thing behind bars. Anybody know what it is? Interpret my images. There's a constitutional responsibility, a constitutional right to medical care for prisoners. It's just about the only constitutional right to medical care under the 8th Amendment, which prohibits cruel and unusual punishment, and for detainees, the 14th Amendment, which provides equal protection for detainees as it does for prisoners. So there are three prongs. The Supreme Court, to be constitutional, there has to be timely access to care, access to an appropriate level of care, and treatment as prescribed by the physician. If that doesn't happen, There's deliberate indifference to serious medical needs. That's the language that's used. And in my role, when I do play expert witness, I am asked to form an opinion about whether there's deliberate indifference to serious medical needs. There is no other driver behind bars. If we find good doctors, sometimes, a lot of good doctors, a lot of good nurses, a lot of good psychologists and social workers, but the driver is litigation or the fear of litigation. And unfortunately, it's not a mission-driven system. So imagine a 19-year-old convicted first felony offense, going to prison. Likely minority, likely poor, likely undereducated, high probability of having serious mental illness. Among adult prisoners, overall, not age adjusted, by very strict criteria, 15% have serious mental illness. 80% of kids in juvenile detention center are medicated for mental illness. That's a different way, a different lens on it. Many of them may be over-medicated and whatever, but there's at least 15%, if not more, prevalence of serious mental illness among the juveniles who sometimes come back into the system. I'm talking about schizophrenia, 3 to 4%, bipolar disorder and major depression, 3 to 5%, major depressive disorder, 8 to 10%, and then among women, a very high proportion with PTSD, less so with men. So there is a lot of mental illness. Likewise, there is a lot of drug use and addictive disorder. Very high risk behavior, risk for medical things, not just for recidivism. When we're talking about risk over these last couple of days, just imagine the risk profile for these folks. And it's likely, this 19-year-old is likely to be somebody who's had very unstable relationships in the community and with family, and who is medically ignorant. Well, how did he get there? This matter of mass incarceration, I think, as I agree with Ed, it cannot be avoided. We've got an incarceration rate that's higher than South Africa by more than 50%. It's higher than Russia by more than 50%. The population rate, incarceration rate right now is about 800 per 100,000. The UK has the highest incarceration rate in the EU, and their rate is 85. So imagine. And this is driven, this isn't because we have bad people here. This is driven by economic and political interests to build prisons in rural areas, to staff them up, to support unions. So the political drive to keep sentences long, punishments severe, and increase in prison beds is a public policy issue of massive proportion. But as people who think about public health, we have got to be there to be able to analyze this with data, to be able to stand up and speak out to show how this is detrimental to the public health of our young people. And the young people in America, and I think it's just so important. We can't avoid that. Okay, well, there's some structural challenges that are unique to the prison environment that I would just like to mention. You take these young people and they come into a highly disciplined environment with a command, control, organizational structure. And you sit there and think, yeah, just like the military, right? That's good for young people. Give them discipline and give them command control. But what's different is there's no mission, patriotism. There's no hope for achievement, promotion, education, job skills. The only thing to look forward to for a young person behind bars is getting out. That's it. So the command control environment, which is alien to them, rigid rules, it's isolating and it's alienating, and it's got, I think, a completely different effect than does a command control environment like the military. So I don't want to spend too much time on this. We've spoken for 2 days about all these risk behaviors and risk factors. There are a lot of suicides. There's no age-adjusted suicide data. I called the foremost expert in the country the other day. It's not there. Um, Pregnancy, about 8% varies according to regionally, but about 8% of incoming women are pregnant when they come in. Um, Most women who come to state prison have a child, at least one, and many of the young men have a child. So we have issues of pregnancy and parenthood, and also we need to think about the impact on the kids of parental incarceration, and there's a little bit of data on that, and it shows it's a pretty negative impact. And at least as important, most incarceration of young people comes from very few communities in each city. You can pick the zip codes. It's 3 to 5 zip codes in any city in the United States. So think about what that does to the social capital of those communities. Think about when we say that poor people are less likely to be married when they have their first child and things like that. Why is that? Well, in part, it's because a lot of the men are locked up, right? So they're not there to develop those things. And wherever there's reduced social capital, of course, there's reduced social control. So challenges that are unique to prison, different from the structural ones, but the separation from family, which for a lot of young people is very meaningful. There's violence in prison. There's victimization in prison. There's what I call adverse mentoring, the just kind of being in contact with bad guys who look good for the moment on the surface. Suicide risk is high. The risk for a young person of being put into segregation, into solitary confinement for long periods of time is really high. One rule infraction, like a fight, could put in the state prison, could put an 18 or 19-year-old in segregation for 6 to 12 months. That means 23 hours a day in the cell, no social contact, rarely a book, limitations on visits. It's really isolating, really alienating. Segregation is overused as punishment for minor infractions. It's becoming a major issue of attention right now, but if you go to any, people are punished for their illnesses in county jails all over the country. I see people who are arrested or otherwise detained. They're acutely psychotic, should be in a hospital, but they're not. They're acutely psychotic. They come in, they're just agitated, and so what do? They put them in segregation. That's the treatment. Is it an evaluation for mental illness? No. The treatment is put him in segregation until he decides to calm down and stop acting out. Think about exercise and nutrition for youngsters. The nutrition is terrible. Exercise options, even for those who are not in segregation, are usually not as good as they would be for energetic young folks out in the community. They've got a healthcare staff taking care of them the staff is professionally isolated from community healthcare folks. The healthcare staff tend to develop the cynicism that custody staff have, and so there is often the cynicism instead of skepticism when someone says, I don't feel well, I have chest pain, I'm bleeding, I'm vomiting blood, or whatever. And then we've got the reentry challenges that everybody knows about, particularly the stigma and the difficulty in returning to the community, where sometimes in their own communities they're not really wanted because they're labeled as criminals in their own communities as well, and the challenges of finding a job. There are a few things coming with the Affordable Care Act that are hopefully we'll be able to have better transfer of medical information in and out. And for the last decade, we've been using the term re-entry. In Europe, they are now using the term through care so that we can coordinate continuity and coordination of care from outside to inside to outside, and I think that's a good point. I just have 2 slides here on what I think are some of the policy challenges, research and policy challenges. We need data. I mean, there are just so few data sets available, and we need, most importantly, to find ways to drive a change in public policy so that we can attend to reducing the rate of incarceration, which will reduce the harm to so many young people caused by incarceration. And we need to be able to have the resources to focus attention to find out what's going to make a difference in health and what's going to make a difference in public health for a highly vulnerable population.